welcome to this targeted deep dive.
Yeah, glad to be here.
So, if you are listening right now, you are a resident deep in the trenches, preparing for your FRCS plastic surgery board exams.
Yep, the final hurdle.
Both of us sitting here at the mics are plastic surgeons, and today we are skipping the fluff, skipping the long introductions, and getting straight into a rapid-fire review of the anatomy and management of the open abdomen.
Straight to the point.
Right. But before we start testing your knowledge, press follow to catch more of these high-yield revision deep dives, and rate the show right now if you find this useful.
Please do.
Also, make sure you get a premium subscription to access the exclusive Journal Club and Clinical Cases episodes.
Those are really essential for exam prep.
Definitely. So today's deep dive is going to be a high-yield question and explanation style discussion designed specifically to get you exam ready. Let's get right to work.
Sounds good.
We're going to kick this off by defining an open abdomen, the laparostomy.
Right, the laparostomy.
A laparostomy is essentially an abdominal wall defect created by intentionally leaving an abdominal incision open at the completion of a surgery.
Yeah, exactly. Or it can occur when a surgical team specifically opens or reopens the abdomen to manage abdominal compartment syndrome.
Right. You also have to consider cases where abdominal wall tissue loss following trauma or extensive tumor resection produces massive defects that simply cannot be closed.
Yeah, the core indications for intentionally leaving that abdomen open fall into a few distinct, heavily tested categories.
What are those?
Well, first you have damage control surgery for severe trauma.
Standard.
Second is severe intra-abdominal sepsis.
Right.
Third, situations where there is excessive visceral edema that physically precludes direct closure without putting unbearable tension on the fascial edges.
You just can't physically close it.
Exactly. And finally, abdominal wound dehiscence, which is a major postoperative complication that carries a very high mortality rate.
Okay, let's unpack this specifically regarding abdominal compartment syndrome, because examiners absolutely love to test you on the precise numbers.
Oh, they obsess over the numbers.
Right. If you are sitting in your Viva, you cannot just say the pressure is high.
No.
You have to know the exact diagnostic pressure readings for intra-abdominal hypertension and what specific clinical shift pushes that diagnosis into full-blown abdominal compartment syndrome.
Yeah, the numbers are absolute key here. Intra-abdominal hypertension is strictly defined as an infra-abdominal pressure greater than 12 millimeters of mercury.
Greater than 12.
Right. And for that hypertension to be formally classified as abdominal compartment syndrome, or ACS, that intra-abdominal pressure needs to exceed 20 millimeters of mercury.
So over 20. But there's a catch, right?
Yeah, there is. The crucial second half of that definition, the part candidates often forget under pressure, is that it must be accompanied by new organ dysfunction.
New organ dysfunction.
Exactly. You cannot formulate the ACS diagnosis without the organ dysfunction component.
There's such a high-yield point.
It really is. And as an added point for your examiners, you should clearly state that this intra-abdominal pressure is usually measured clinically, using an intravesical probe.
Right? That means measuring the pressure indirectly through the bladder.
Precisely.
So knowing those pressure parameters dictates when the abdomen is left open. But the real surgical challenge for boards is proving you know exactly what you're cutting through to get there.
Absolutely. Anatomy is the bread and butter of our specialty.
Let's run through the layers of the interior abdominal wall, dissecting from superficial to deep.
Sure.
Starting at the very surface, you obviously have the skin.
Yep.
Immediately deep to that is the subcutaneous fat, which sits within Camper's fascia.
Campers. And going one layer deeper, you hit Scarpa's fascia.
Now, a critical landmark detail here that examiners use as a trap it.
Oh, yeah.
Scarpa's fascia only exists below the level of the umbilicus.
Exactly. If you are describing an upper GI case or an epigastric defect, do not mention Scarpa's fascia.
They will fail you on the spot.
Pretty much. Deep to Scarpa's, you find the subscarpa's fat layer.
Right. Yeah,
Continuing the dissection deeper from that subscarpa's fat, you encounter the primary fascial layers. Centrally, you have the anterior rectus sheath.
And laterally.
Laterally, you have the aponeuroses of the oblique muscles. Deep to this fascial layer are the muscles themselves.
Okay.
Once you pass through the musculature, you hit the posterior rectus sheath. But again, there is a structural caveat you must explicitly state.
Which is?
The posterior rectus sheath is only present above the arcuate line.
Above the arcuate line, got it.
Right. Continuing deeper past that, you find the transversalis fascia, then the preperitoneal fat, and finally the deepest layer protecting the viscera, the peritoneum.
Here's where it gets really interesting, because the muscle layers and their fascial envelopes are not just stacked flat like pages in a book.
No, not at all.
They interact dynamically to form the rectus sheath. You can divide the muscles of the anterior abdominal wall into two distinct groups. First, the longitudinally orientated centrally placed muscles.
That's the rectus abdominis and the much smaller pyramidalis.
Right. And second, you have the flat, laterally placed muscles.
Those flat lateral muscles are the external oblique, or EO,
Yep.
the internal oblique, IO,
Okay.
and the transversus abdominis, TA. As these three lateral muscles travel medially toward the center of the abdomen, their aponeuroses fuse just lateral to the lateral edge of the rectus abdominis.
And this specific fusion line is the linea semilunaris.
Exactly, the linea semilunaris. After this initial fusion, the fascial fibers divide again into anterior and posterior laminae.
Right.
These laminae physically enclose the rectus abdominis muscle, wrapping around it to create the rectus sheath.
Like an envelope.
Like an envelope. And finally, after enveloping the muscle, they meet in the absolute midline and fuse together to form the linea alba.
You mentioned the posterior rectus sheath only exists above the arcuate line.
I did.
That is one of the most high-yield anatomical concepts for this exam. The arcuate line is essentially the free inferior edge of the posterior lamina of the rectus sheath. The posterior lamina is completely deficient below the level of the anterior superior iliac spine, and this lower anatomical border is the arcuate line. You will find it located approximately 1/3 of the distance from the umbilicus to the pubic symphysis.
Right.
Its clinical significance lies entirely in how the aponeuroses of those three lateral muscles arrange themselves around the rectus abdominis muscle above versus below that line.
Yeah, so above the arcuate line, the anterior rectus sheath is made up of the aponeurosis of the external oblique and the anterior leaf of the internal oblique aponeurosis.
Okay.
The posterior rectus sheath is made of the posterior leaf of the internal oblique and the transversus abdominis aponeurosis. The rectus muscle is sandwiched securely between them.
But below the line.
Below the arcuate line, the structural anatomy completely changes. In that lower third, all three of those aponeuroses, the EO, IO, and TA, pass completely anterior to the rectus abdominis.
They all go to the front.
They all go to the front. Because all the fascial support has shifted to the front, the posterior surface of the rectus abdominis below the arcuate line rests directly on the transversalis fascia.
There is no posterior fascial sheath at that level.
Exactly, which is a frequent site of structural weakness that examiners will want you to recognize.
Let's finish up the anatomy section with the neurovascular supply.
Good idea.
The neurovascular plane is found running securely between the internal oblique and the transversus abdominis muscles.
Right, between IO and TA.
For the nerve supply, these muscles have a segmental innervation running from T6 or T7 down to T12. You also have to specify that the external oblique is supplied by the iliohypogastric nerve, which takes roots from T12 and L1.
Yeah. And the internal oblique shares that iliohypogastric supply, but also receives innervation from the ilioinguinal nerve, which is L1.
What about the arteries?
On the arterial side, you must cite a rich, redundant network. You have the segmental, intercostal, and lumbar vessels. Vertically, you have the superior epigastric arteries coming from above, and the superficial and deep inferior epigastric arteries coming from below.
And laterally.
Laterally, you have the superficial and deep circumflex iliac arteries, and finally, the superficial external pudendal arteries. Recognizing this vast vascular network is critical when you start planning complex flaps for reconstruction later on.
That covers the foundational anatomy. Shifting to the clinical management of the open abdomen, the surgical team needs a shared language to describe the severity of the wound on the ward.
Right, you need a standard classification.
The standard classification you need to recite is the Bjork classification, which stages the open abdomen from grade 1 through grade 4 based on the degree of fixity and complications.
Let's break those down.
Grade 1 is an open abdomen without any adherence between the bowel and the abdominal wall and no fixity of the abdominal wall itself, a state we call lateralization.
Yeah.
Grade 1 is subdivided into A for a clean field and B for a contaminated field.
Moving to grade 2. This is an open abdomen that is actively developing adherence and fixity. The viscera are starting to stick.
Right.
Like grade 1, it is subdivided into A for clean and B for contaminated.
Okay, what about grade 3?
Grade 3 is where the clinical picture gets much more complex. This is an open abdomen complicated by fistula formation.
Fistulas are a nightmare.
Absolutely. Finally, grade 4 is the most severe presentation. This is the frozen open abdomen. The bowel is completely adherent and fixed. It absolutely cannot be closed surgically due to the density of the adhesions, and it may present with or without a fistula.
With that Bjork classification establishing the severity, examiners will want to know your overarching strategic framework.
The big picture timeline.
Exactly. The management timeline is strictly divided into 3 sequential phases. Phase 1 is temporary abdominal closure, or TAC. Phase 2 is patient optimization. And Phase 3 is definitive closure. Let's break down Phase 1, temporary abdominal closure.
The primary clinical goals of temporary closure are to protect the intestines from physical trauma, to maintain a sterile or at least a clean environment, and crucially, to avoid massive fluid and temperature loss from the exposed viscera.
To achieve this mechanically, you have a few specific methods at your disposal.
Yeah, you can use skin-only closure using towel clips for an immediate, rapid solution in unstable patients.
Okay.
There is the silo technique, which involves using non-adherent plastic sheets to literally wrap and contain the intestines.
Right.
You can use a temporary mesh. You can use intraperitoneal packing.
Yep.
You can utilize negative pressure wound therapy, which protects the viscera while managing the heavy exudate. There are also various proprietary medical devices designed specifically for managing this temporary phase.
So what does this all mean? Once you have the temporary closure in place, you enter Phase 2, patient optimization. We are usually dealing with critically ill ICU patients at this stage.
Yeah, they are very sick.
You need a highly systematic approach, and the best way to structure Phase 2 for an examiner is by using the SNAP principle. SNAP. Thorough optimization maximizes your chances of a successful final reconstruction. The S stands for sepsis control. You have to aggressively manage both the localized intra-abdominal infection and the broader systemic inflammatory response.
The N in the SNFP protocol is for nutrition. These patients are in a highly catabolic state due to the massive physiological stress and the protein loss from the open wound. They almost universally require aggressive supplemental enteral or parenteral feeding.
You cannot rebuild a massive fascial defect if the patient is nutritionally depleted.
Exactly. The A stands for anatomy. You need to precisely define the physical defect using preoperative imaging to understand exactly what native tissue is left.
And the P.
Finally, the P is for planning. Based on that radiological anatomy and the patient's nutritional and physiological condition, you must determine the exact type and extent of reconstruction required for Phase 3.
That brings us to Phase 3, definitive closure and reconstruction. Obviously, some small wounds might be amenable to delayed primary closure or simply healing by secondary intention.
Right.
You might even use skin grafts directly onto bowel or granulation tissue just to stop the massive protein losses in patients who are simply too unstable for major surgery.
Yeah, that happens.
But when we talk about actual structural reconstruction of the myofascial layer, you should divide your operative options into 3 main categories: prosthetic, bioprosthetic, and autologous reconstruction.
Let's compare prosthetics and bioprosthetics.
Sure.
Prosthetic materials can be meshed or non-meshed, absorbable or non-absorbable. Mesh materials are often beneficial because they allow continued drainage of the abdominal cavity, and granulation tissue can actively grow right through the interstices of the mesh to permit delayed skin grafting directly on top of it later on.
Okay.
Alternatively, you can cover a mesh with an omentum flap and skin graft over that, though that requires leaving a small fascial defect specifically for the omentum's vascular pedicle. When comparing synthetic meshes, you must state clearly that absorbable meshes are associated with significantly higher rates of fistula formation and late hernias compared to non-absorbable polypropylene meshes, like Marlex.
This raises an important question regarding infection, which is the primary reason bioprosthetic reconstruction is heavily tested. A cellular dermal matrix, or ADM, has become a massive topic in hernia and abdominal wall repair.
Oh, massive.
ADMs tend to form far fewer adhesions with the underlying bowel compared to synthetic prosthetic materials. Because certain ADMs incorporate into the host by biological regeneration and are eventually repopulated and replaced by native tissue, they can be used in infected or contaminated wounds with relative impunity compared to synthetics.
However, they are not a magic bullet, and the examiner wants to know that you understand the mechanical limitations.
Right.
ADMs generally lose their structural integrity and stretch out over time when used purely as bridge grafts across a large ventral hernia defect.
They just stretch out.
Yeah. This mechanical failure leads to very high recurrence rates, if you were relying on them to bridge a gap rather than reinforce a primary fascial closure.
If prosthetics and bioprosthetics have limitations, especially when bridging large gaps in a contaminated field, we turn to autologous reconstruction. We have several reliable autologous options to borrow native tissue.
Quite a few.
You can use fascia lata, either taken as a free graft or utilized as a pedicled tensor fasciae latae flap. This fascia can also be transferred as a vascularized component of an anterolateral thigh, or ALT flap.
Then you have a wide array of muscle flaps from local or distant sources.
Right.
You can use the rectus abdominis itself, mobilizing it either as a transposition or a turnover flap. You can use the external oblique for upper abdominal defects or the internal oblique for lower abdominal defects.
And if those aren't available?
If those local options aren't viable due to the initial trauma or previous surgeries, you can harvest the latissimus dorsi, rectus femoris, vastus lateralis, or the gracilis. These can be brought in either as pedicled or free flaps, depending entirely on the physical reach and the vascularity required for the specific defect.
Now for the ultimate FRCS board question.
There we go.
When direct closure is impossible due to the sheer size of the gap, but you want to use the native abdominal wall musculature rather than relying on distant flaps or bridging meshes, you use component separation. Specifically, examiners will ask you to describe the classic Ramirez technique.
What's fascinating here is the sheer mechanical genius of the Ramirez technique. Component separation allows for a massive advancement of the myofascial layers toward the midline to achieve direct closure without excessive ischemic tension.
How does it work?
It relies on making releasing incisions at very specific, predetermined points in the deep fasciae. The first step is to divide the external oblique aponeurosis from the rectus sheath just lateral to the linea semilunaris.
Okay, that's step one.
The second step is to separate the rectus abdominis muscle from the posterior rectus sheath by incising the medial edge of the sheath and bluntly freeing the muscle from its posterior attachments.
Right.
By releasing these specific lateral tethers, the entire rectus complex can physically slide medially.
The examiner is going to demand the exact advancement yields of that release. When you perform this bilateral release, what are the specific distances of advancement you gain in the different anatomical zones of the abdomen?
You've got to know these numbers.
Bilateral advancement of the rectus muscles and the anterior rectus sheath yields exactly 5 centimeters in the epigastrium,
5 up top,
a massive 20 centimeters at the umbilicus,
20 in the middle,
and 6 centimeters in the suprapubic region. You have to know those three numbers cold. 5, 20, and 6.
If you need even more tissue because the defect exceeds those advancement yields, you should mention to the examiner that tissue expansion can be used prior to this advancement.
Good point.
Expanders can be strategically placed either between the external and internal oblique muscles or in the plane between the internal oblique and the transversus abdominis, generating more native tissue before you execute the Ramirez release.
To close out the clinical section, let's list the complications. You perform the reconstruction utilizing either mesh, ADM, or component separation. What are the common post-operative complications the surgical team needs to monitor for on the ward?
The most common and critical post-operative complications include complete wound dehiscence,
Terrible.
the development of an entericutaneous fistula, late hernia formation, infection of the prosthetic mesh, which, as we know, almost universally requires a return to the OR for complete surgical removal.
Right.
And finally, the formation of persistent seromas, especially after extensive lateral dissection in a component separation.
If we connect this to the bigger picture, particularly regarding the materials we use, considering that acellular dermal matrices are incredibly useful because they resist infection in contaminated fields, yet they fail structurally and stretch out when used as bridge grafts over large defects, it really makes you wonder about the future of abdominal wall reconstruction.
Exactly. How might the next generation of hybrid biomaterials be engineered to bridge this mechanical gap, providing the long-term tensile strength of a synthetic mesh, without compromising that incredible biological resistance to infection seen in ADMs? It is a fascinating frontier in tissue engineering that will likely change how we manage the open abdomen in the next decade.
You've made it to the end of this rapid-fire deep dive. Congratulations on completing this high-yield revision. If you've been listening, I want you to leave a comment or question below to test your knowledge or ask for clarification on anything we covered today for your board prep. Keep studying hard.